Thank you so much. And thank you. I'm very happy to be here. And thank you very much for invitation to Professor Iryna Vlasenko and her team. Thank you. I will speak about effectiveness of diabetes therapy. If you look, but before I want to remind economic impact of diabetes. IVF estimated the annual global health expenditure of diabetes. It costs 760 billion, and indirect cost of diabetes add an additional 35% to the annual global health expenditure associated with diabetes. But if you look at Europe, diabetes-related expenditure per person increased for every country except Greece during the last 10 years approximately. And the cost now is 2,030 per person with diabetes. Now, it is also interesting that healthcare costs are higher for men than they are for women. It's discrimination, I think. But we must remember that men are at slightly higher risk for type 2 diabetes than women, and we more expect more cost. Very interesting global economic burden of diabetes, which shows that prognosis projection from 2015 to 2030 that it increased in twice, and in 2030 it will be 2.5 trillion dollars. Policymakers need to make urgent action to prepare health and social security system to mitigate the effects of diabetes. And of course, directly costs include price of insulin, which is very high now, and according, I find only one report from Massachusetts Health Policy Commission that 40% insulin more use now use for insulin now than few years ago. But I hope biosimilar can help to us, and not only because they have lower price, but also will reduce the price of human and analog insulin by increasing competition. And biosimilar insulins demonstrate that are safe and effective, but interoperability and automatic submission remain as an issue. But this we must remember and resolve discussion that find that complication prevention and glycemic control are widely recognized as the most effective way to control diabetes treatment costs. We know this. What we must do, decrease of cost, way to prevent the adverse consequences of diabetes, promote awareness about diabetes, promote lifestyle changes, patient education, adequate and promotion management. We know this, but we must continue working in this area, and this is also according to new resolution WHO about how we can decrease burden of diabetes. It's the same point. And use of diabetes self-management education as associated with low total medical cost and low total prescription medical cost. This is very interesting. There are 30 years cost effectiveness of alternative strategies to achieve excellent glycemic control in type 1 diabetes shows that if intensive therapy achieves and maintains excellent glycemic control, the greater cost of intensive therapy with type 2 diabetes and pumps are substantially offset by the reduced cost of complication, comorbidities, and improvement in health-related quality of life. They also highlight the economic benefit of delivering intensive therapy at as low a cost as possible. The use of expensive insulin and device as a general treatment strategy will reduce the cost effectiveness of intensive therapy unless they achieve better clinical outcome. Intensive therapy using pump by CGM is not currently cost-effective and as a general treatment strategy because of the substantially greatest cost and essential long-term clinical superiority. Pump therapy with CGM may still be an appropriate therapy for selected patients who have poor glycemic control and problematic hypoglycemia, and to achieve improvement long-term outcomes with such therapy. In this context, it's also new research from Denmark that for diabetes type 2, that achieving early and intensive glycemic control, thereby minimizing therapeutic inertia, can lead to substantial saving for the society, ranging between 10 million euro till 51. It's only for this society, for Denmark. This study highlights the efforts to minimize therapeutic inertia by securing timely intensification before individual AASD targets are exceeded, result in significant long-term cost saving. And a few examples in this medication. CGLT2E have demonstrated reduction in cardiovascular and renal complications, including hospitalization for heart failure and renal disease progression in randomized clinical trial. And the highlight the need to consider cost saving from reducing comorbid and preventable type 2 diabetes complication when considering the cost of diabetic medication. Compare this treatment with evaluation of long-term cost-effectiveness 1 week semaglutide versus diglutide for treatment of type 2 diabetes. In UK was a research and showed that cost-effective option for treated individuals with type 2 diabetes who are not achieve glycemic control with metformin. Patient prescribed multi-daily injection of basal bolus insulin therapy for type 2 diabetes have greater disease burden, experience greater medical costs and healthcare resource utilization, and exhibit poorer glycemic control than patients treated with an oral anti-diabetic drug on basal insulin therapy in the strange form. When that is studied. When you statin therapy and secondary prevention, secondary prevention, there is a clear value to statin use cost saving individuals with diabetes with and without cardiovascular disease. However, for primary prevention, statin use has been found to be less cost effective. The cost effective of intensive glycemic management depends on age and duration since diabetes diagnosis. And bariatric surgery was cost-saving among individuals with type 2 diabetes and obesity, but only very cost-effective among individuals with type 2 diabetes and overweight, likely due to larger health risks caused by obesity. Now, how we can decrease cost effectiveness? You see that we can use mHealth, and this is mHealth technology, reduce cost associated with medical care and reduce the cost of repeated hospitalization by 55%. Of course, we use telemedicine in diabetes, and this is, of course, reduce cost because not visit to doctor, but in the same time we must remember that telemedicine has a lot of barrier, lack of acceptance and doubt about its effectiveness, availability, potential technical problem, regulatory issue. In this case, now find a lot of research show that part of our patients who have not this possibility have live without medical care. Must remember about this. And few aspects we must remember which can decrease our cost effective, because only in 20% increase in adherence can save $1,000 in total healthcare spending for each patient with type 2 diabetes. And also, economic aspect of medication errors has been estimated like 42 billion annual. And I'm a pharmacist, I work in this area, and I know a lot of research which show that involvement of pharmacists in care of diabetes significantly improve glycemic control, quality of life, and reduce the cost of diabetes care and resource use compared to usual care. And we can use any possibility for decrease our cost treatment of diabetes. Time for action. Immediately action is needed to stem the tide of diabetes and to introduce cost-effective treatment to reverse these trends as diabetes. Thank you so much for your attention.